talk on our session is by Dr. Greeshma. Thank you. She will be speaking on crystalline retinopathy. She is an assistant professor in RIU Trivandrum. Over to you, Greeshma.
Thank you, Papa Madam, for giving me this opportunity. Good afternoon, everybody. Today, my talk is on crystalline retinopathy. So, what is the importance of crystalline retinopathy in systemic drug toxicity? Let's find out. So, I'll be dealing with the clinical case, the causes of crystalline retinopathy, investigations, differential diagnosis, and treatment modalities. So, I had a 45-year-old gentleman. He came to me with decreased vision in both eyes for the past 2 years. His best corrected visual acuity was 6/9 in the right eye and 6/18 in the left eye. His anterior segment was normal and the corneas were clear. Fundus examination showed bilaterally normal optic disc with fine refractile crystals at the macular region. So, continuing with the history, on retrospective analysis, he was identified to be a case of familial adenomatous polyposis, and he had a history of recurrent abdominal desmoid tumor, because of which he had multiple surgical excisions and he was put on high dose chemotherapy. His chemotherapeutic agent was tamoxifen, which was given for 12 years, for the past 12 years, 100 milligram per day. And for him, the cumulative dose came to around 430 grams. The toxic cumulative dose of tamoxifen is more than 100 grams, and hence after consulting with the oncologist, tamoxifen was discontinued. So here, however, he didn't have any CHRP lesions, and the mean prevalence of congenital hypertrophy of retinal pigment epithelial lesions in a case of FAP is around 76%. That is according to a systematic review by Bonnet et al. So coming to the investigations, autofluorescence in a crystalline retinopathy does not show the crystalline bodies as such. However, there can be granular hyperautofluorescence in distressed RPE, and when the RPE atrophies, as we have discussed, there can occur hypoautofluorescence. The earliest modalities which can be used are multifocal ERG and microperimetry. So this was the OCT of the patient. Right eye showed fine crystalline deposits in the inner retina. Left eye, in addition to the crystalline deposits in the inner retina, there were foveal pseudocysts. So the OCT changes expected in a crystalline retinopathy are crystalline deposits, which can actually occur in any layer of the retina, but in tamoxifen retinopathy it occurs in the inner layer. Thinning of the inner retina, foveal pseudocyst, cystoid macular edema, atrophic macular hole, ellipsoids on band loss, and in the later stages, very advanced stages, there can be reduced subfoveal choroidal thickness. So this was a OCT angiography of this patient. Right eye was normal, and even the left eye showed normal superficial and deep capillary plexus. So the octa changes actually come only in the later stages because vascular alterations occur in tamoxifen retinopathy at an advanced stage. So the changes expected are decreased capillary density, microvascular dilatation, increased flow voids, and telangiectasias. Fundus fluorescent angiography was not done in this patient because it was not indicated. If there is a cystoid macular edema, it can show a petalloid leakage. These foveal cavitations which can occur do stain, but they do not leak. And there can be hypofluorescence because of the block by the crystalline bodies. So coming to the drugs responsible, the most important is tamoxifen. It is used in various neoplastic conditions as well as gynecomastia. The prevalence of tamoxifen retinopathy is from 1.5 to as high as 12%. And we usually use tamoxifen for breast cancer, which is the most common indication, and I want you to know that for breast cancer also it can go well above the toxic cumulative dose, depending on the dose of the drug and the duration for which it is used. So coming to the ocular toxicity of tamoxifen, as discussed, it can cause vortex keratopathy, optic neuropathy, vascular occlusions, and bullseye maculopathy, and features of crystalline retinopathy. So according to a case report, it was shown to affect the recovery of CSCR, or it can delay the recovery of CSCR. The treatment, the mainstay is after consulting with the oncologist to stop the drug, and the visual function and edema respond to the stoppage. And the treatment options if cystoid macular edema is there are intravitreal anti-VEGF, steroid and oral acetazolamide. So previously screening was thought only in high doses, but now it is recommended a baseline visual screening. So before you start a patient on tamoxifen, ideally the baseline visual function has to be screened, and once the duration of treatment crosses 2 years, every 6 months screening should be done. Screening is basically by a fundus examination and SD-OCT, because OCT only picks up the early pseudocystic changes of the macula. The most important differential of a tamoxifen retinopathy is MACTEL-2. The clinically both are very similar, except that in tamoxifen retinopathy you obviously have the history of drug intake, and in MACTEL-2 there is higher chance of pigment plaques and neovascular membranes. Also note that in MACTEL-2 crystals do spare the fovea, and OCTA shows more changes in a MACTEL-2. The vascular changes are more prominent in a MACTEL-2. So other drugs causing canthaxanthin are other drugs causing crystalline retinopathy are, one is canthaxanthin. It is used in the treatment of skin diseases like protoporphyria and eczema, and it is also used as an orange food color in the dishes. So it can cause yellow-orange crystals in the inner retina, and the crystallization rate is higher when the patient has a retinal disease, already a retinal disease, and beta carotene intake. Other drugs are methoxyfluorine. It is an inhalational anesthetic. So when a patient has renal failure, you give the drug, it fails to excrete and get crystallized. And intravitreal tricot, because it is water insoluble, it can get crystallized. So coming to another important thing is talc retinopathy. So what chronic IV drug abusers do is that they crush the tablet and inject intravenously. These large particles will be filtered out by the lungs, but the smaller ones can go and block the retinal vessels, leading to ischemia plus crystal deposits. So it follows the line of ischemic retinopathy management plus counseling. And nitrofurantoin is a rare cause, and always keep in mind the other causes of crystalline retinopathy like metabolic, genetic and degenerative. And cystinosis is one very important metabolic cause. This was a 14-year-old girl who presented with multiple crystals, conjunctiva, cornea, lens and the iris. Okay, she was diagnosed with juvenile cystinosis, and this was a patient of age-related macular degeneration. He had cholesterol crystals with geographical atrophy. You can very well see in the hypofluorescence in the second image. So take-home messages are: remember the causes, systemic, ocular and the drug-induced causes, screening of tamoxifen retinopathy as I said, and in a non-diabetic young patient with ischemic retinopathy and crystalline retinopathy, always consider talc retinopathy as a differential. Thank you so much.
Thank you, Greeshma, for that wonderful talk. So what happened to that patient, Greeshma?
Madam, for that patient, actually there was no much changes. His vision remained stable after we stopped tamoxifen, and it did not progress. But you have to remember one thing, that if the patient has cystoid macular edema, it will respond to the stoppage of drug, but the crystals will not resolve. Thank you.
Any questions from the audience? It is interesting that IVT also can cause. So we are giving what about the Ozurdex, the long-term steroids? So I think we have to see, no? So thank you all for the patient hearing. So we can conclude the session. Thank you.